Hello everyone, I am Dr. Irfana. I am consultant infectious diseases. So we'll be continuing with the series of introduction to ID lectures. So this will be my second lecture. So this is my profile, and so we'll be discussing today introduction to fungal infection, which we see in routine day-to-day practice, the basics of fungal infection. So if we see fungal infections, it can be divided into yeast infections and mold infections. So in yeast, usually we see Candida, Trichosporon, Cryptococcus, Histoplasmosis, and mold we routinely come across Aspergillus and Mucorales group of organisms which contains Mucor, Escherichia, Cunninghamella, Rhizopus. All these species come under Mucorales group of organisms which are molds. So these are the fungal markers, beta-D-glucan and galactomannan are the fungal markers which are being routinely used in our practice. And TDM is therapeutic drug monitoring. So we'll discuss each thing in detail. Coming to TDM, therapeutic drug monitoring, it is also important in fungal infections in addition to bacterial infections. So therapeutic drug monitoring is important, extremely important for voriconazole because voriconazole has got genetic polymorphism. Each patient has a different genetic polymorphism like CYP2C19 polymorphism. Some patients can metabolize it very rapidly and they will not be able to achieve the therapeutic drug level. So some patients will go overboard and they'll end up in toxicity like visual hallucinations, hepatotoxicity with voriconazole. So it is extremely important in voriconazole to have therapeutic drug level monitoring, which needs to be done on fifth to seventh day after starting voriconazole, and it should be done 1 hour before giving the next dose of voriconazole, that is voriconazole trough level, and the target should be maintained between 2 to 6, the level of voriconazole. This is important because of the genetic polymorphisms and drug-drug interactions which happen with voriconazole, because it is metabolized by CYP, cytochrome P450 pathways. So if we are giving with other chemotherapy medication, there will be a lot of drug interaction and they can be underdosing or overdosing because of the polymorphisms and drug interactions. And coming to posaconazole and isavuconazole, posaconazole also needs therapeutic drug monitoring in chemotherapy patients or cancer, blood cancer or third organ cancer patients. So the dose or the target level is different for prophylactic and therapeutic voriconazole. For prophylactic, it should be more than 0.9 and the level should be more than 0.9, and for therapeutic, the level should be more than 1.1. That is what we have to aim for posaconazole, because it will also have drug interaction. And isavuconazole, the pharma companies have not recommended drug monitoring for isavuconazole, but in critically ill patients with joint or bone infections or brain infections, it will be better to monitor the therapeutic drug monitoring and adjust the dose, and if needed, maybe give a little bit of higher dose for these critically ill patients. And here, so one point I would like to discuss here is that in atrial fibrillation patients, the QTC prolongation may worsen the fibrillation. So voriconazole and posaconazole have the tendency to cause the QTC prolongation if individually, as well as if they are given with other QTC prolonging drugs like levofloxacin, clarithromycin. So if there is a patient with atrial fibrillation and you're giving voriconazole, posaconazole, definitely we have to monitor the QTC, and if it is going over the board, we may need to change it to amphotericin B, or isavuconazole is a good option because isavuconazole causes QTC shortening and not QTC prolongation. So going to the next slide. So this is the stereotypic presentation of two different types of fungi. This is description is thin, acute angled, thin, septate. You can see the septa here. This is septate hyphae. This is typical of Aspergillus and other organisms like Fusarium, the septate group of organisms. Here, if you see, these are broad, ribbon-shaped and aseptate or posiseptate type of fungal hyphae. So this is a typical description which you can see for Aspergillus, and this is for mucorous group of organisms. But in septate fungal hyphae, it doesn't only mean Aspergillus, it has other organisms also like Fusarium, Scudosporium, and here also broad aseptate could be other organisms like Conidiobolus, Basidiobolus. But when you see the typical description like thin, hyaline, thin acute angled septate hyphae, you have to think of Aspergillus, and here you have to think of mucormycosis. This is a calcofluor stain, which is an fluorescent stain which can easily recognize these organisms. And coming to Aspergillus and mucor and the fungal markers, so BDG is beta-D-glucan. 1,3-beta-D-glucan is a component of the cell wall of fungi. So this is a fungal marker which can detect whether there is a fungal infection or not. So usually beta-D-glucan is a pan-fungal marker. It is positive in many fungal infections like Candida, Aspergillus and other group of organisms, but it is negative for mucormycosis and blastomycosis and cryptococcosis. Other than that, many other fungal infections cause positive beta-D-glucan. So in Aspergillus, it is positive, but in mucormycosis, it will be negative. Coming to galactomannan, which we send routinely, so it is also positive in Aspergillus, but galactomannan will be negative for mucormycosis. This is how you can differentiate. BDG and galactomannan both will go hand in hand, and it will be positive in Aspergillus, but in mucor both will be negative. There is no fungal markers for biomarker for mucormycosis. You have to depend on the histopathology and the cultures only. And galactomannan will come positive in other fungal infections like histoplasma as well. So oriconazole and posaconazole. So if any patient is having fungal infection in your HRCT is showing fungal nodules, ground glass opacities, halo signs, reverse halos, all these things, but when you don't have these fungal markers, then the issue with voriconazole is that it will select out mucormycosis if it is there in the background. If you are giving voriconazole for a patient without knowing what kind of mold it is, if the mucor is there in the background little bit, it will worsen with voriconazole because voriconazole will select out mucormycosis. That's why if you are not sure that the patient is only having Aspergillus or specific group of organisms which will respond to voriconazole, you can't prescribe voriconazole because it will select out mucor. But coming to posaconazole and isavuconazole, these drugs have the advantage that they'll cover both voriconazole, both mucor group of organisms as well as Aspergillus group. So posa and isavuconazole are better to give if you don't have the proper diagnosis of what fungus it is. So if you see COVID patients during peak COVID, we used to get mixed kind of fungal infections with both Aspergillus and mucor coming from the rhinocerebral mucormycosis or patients post-COVID. But the Aspergillus which is there in the specimen, it could be just local colonization or it could be true infection. So it is very difficult to decide. In that situation, you have to give either posa or isavuconazole so that it covers both Aspergillus and mucor when you have either mixed infection or when you don't know which type of infection you are treating. This situation comes in our day-to-day practice frequently. So beta-glucan and galactomannan have their own sensitivities and specificities. Beta-glucan has a very good negative predictive value. That means if you are having a patient in whom we are suspecting candidiasis and you have done the beta-glucan, if the two sequential beta-glucans are negative, then it is implied that the patient doesn't have candidiasis. It has a very good negative predictive value when compared to the positive predictive value. So you can have false positive beta-glucans in many situations. So any recent surgery of less than a week, you use gauze during surgery which has lots and lots of beta-glucan. So that's why any recent surgery will have very high beta-glucan, and you have to take it with pinch of salt and try to not send beta-glucan within 1 week of surgery. And intravenous albumin, which we use very frequently in our ICUs, so that also has very high beta-glucan to the level of 20,000 also sometimes. So any patient with recent albumin administration also, you have to read the BDG values with caution. And intravenous immunoglobulin and any local dressings with gauzes, these situations will have high beta-glucan values. And one more thing is false positive galactomannan is seen with generic piperacillin tazobactam. This one also you have to remember. So these fungi, Candida, Pneumocystis, carne, pneumonia, Aspergillus, Fusarium are few examples of positive beta-glucan. And for galactomannan, I have already told you Aspergillus and Histoplasma. So if you take PCP, Pneumocystis carne or Pneumocystis erythritidis pneumonia, so it has a very good correlation with beta-glucan. Sometimes you can even rule out PCP if the BDG is negative. The level of BDG also is very, very high in Pneumocystis cerevisiae pneumonia. You can correlate with this thing if you don't have the PCP stain, Ginza stain or PCP immunofluorescence. Also along with the HRCT or chest X-ray findings, compatible host. One more thing I wanted to tell about galactomannan is that the sensitivity is different in neutropenic as well as non-neutropenic patients. So galactomannan is phagocytized by the neutrophils. So neutrophils eat away the galactomannan. So in a neutropenic patient, there is no neutrophil to eat away the galactomannan. That's why the galactomannan level will be high. That's why the sensitivity of galactomannan in a neutropenic patient, specifically in hemat patients, is very good. But if you take a normal ICU patient without any neutropenia, the sensitivity of galactomannan is less because whatever the neutrophils are there in the body that eats away the galactomannan. That's why the sensitivity of galactomannan in a non-neutropenic patient will be less. And coming to drug interactions. So drug interactions are not only important for the azoles, but any drug in our routine practice, we have to see the drug charts routinely and see whether there are any interactions. The interactions may lead to underdosing, not achieving level subtherapeutic drug levels as well as toxicity. So here, if you see the example of voriconazole and cordon, this is basically this combination causes prolonged QTC. So when the patient is having AF and cordon is also ongoing and the patient is on voriconazole, prolonged QTC may even worsen the atrial fibrillation, and that thing you have to remember. And second thing is voriconazole with vincristine. In hemat patients like AML patients, when you are using voriconazole along with vincristine, the combination will lead to vincristine toxicity. So you may have to decrease the dose of vincristine. So basically, azoles are enzyme inhibitors. So they'll increase the concentration of the other drug by decreasing the metabolism. And venetoclax is also used in these patients. And this is usually used as jugaad by the primary physicians also, because the venetoclax is so expensive, and you can decrease the dose of venetoclax by using voriconazole. Thereby, you are treating both, like you are treating the fungal infection and treating the primary malignancy also. And next, moving on to rifampicin and azole. So rifampicin is very strong enzyme inducer, and it decreases the levels of azole. So if you are having a patient with TB as well as fungal infection, which you come across routinely, so rifampicin will decrease the levels of azoles very significantly. Sometimes you will have even 0 to 10% of the level of the antifungal. So when you are giving a combination therapy of with these medications, you have to either drop off one medicine and give an alternative, like you can stop rifampicin and you can modify the antituberculosis medication and replace it with levofloxacin, and you can continue the antifungal medication. It depends on the situation. And azoles and CNI. CNIs are calcineurin inhibitors like tacrolimus and cyclosporin. So the azoles, as we have discussed, are enzyme inhibitors, and it increases the levels of tacrolimus and cyclosporin, and which leads to neurotoxicity as well as nephrotoxicity. The patient can land up in seizures, altered sensorium, hypertension. Basically, this is the CNI toxicity which will worsen the patient. When we go back to the drug chart and see these two drugs, if we can stop azoles or decrease the concentration of the calcineurin inhibitor, drug of calcineurin inhibitors, the patient will improve. Second thing is monitoring the level of calcineurin inhibitors like TAC levels and cyclosporin levels, which we do routinely. And so voriconazole, isoamphocyanine. So voriconazole we use for aspergillus, fusarium, pseudosporium. Posa and isavo we can use if we are suspecting other fungal infection also, like mucor. And so posaconazole, the side effects of posaconazole are hypokalemia and prolonged QTC. So we have to monitor these two, as well as liver function test. It can cause hepatitis with increase in the SGOT and SGPT. So that needs to be monitored frequently, at least 1 to 2 times in a week, even after discharge. So isavuconazole causes shortening of the QTC, but it can have liver toxicity, but it does not cause hypokalemia. It can cause hyperkalemia. So amphotericin, you all know that it causes severe hypokalemia as well as hypomagnesemia. Sometimes it can cause drug reactions, infusion reactions, and nephrotoxicity. So you have to give pre-hydration, post-hydration, monitor the levels of creatinine, potassium, adjust during the clinical course. So in amphotericin B, the important thing is that you don't need to sequentially increase the dose of amphotericin. For example, if the patient is having aspergillus, you give 3 to 5 mg per kg body weight of amphotericin for aspergillus. You don't need to give 50 mg day 1, 100 mg day 2, 150 mg day 3. You have to directly start 3 mg per kg body weight for the patient. Likewise, for mucormycosis, 5 mg per kg body weight of liposomal amphotericin B, you can give it directly on day 1 only. For conventional amphotericin B, the dose is 0.7 to 1 mg per kg body weight only. So you have to always write on the drug chart specifically whether you want to give liposomal amphotericin B or plain amphotericin B is amphotericin B deoxycholate. Sometimes we see that we write the dose of liposomal amphotericin B like 300 milligrams for a 60 kg patient, and the patient gets 300 mg of conventional amphotericin B sometimes. So we have to be very specific while writing the prescription as well, whether we want to give liposomal amphotericin B or conventional amphotericin B also. And coming to echinocandins, so one point I would like to highlight is that caspofungin or any echinocandin is not the drug of choice for invasive aspergillosis. It is only a salvage therapy only. So it should not be given as monotherapy for invasive aspergillosis unless there is a severe hepatotoxicity and you don't have any other option to give. Otherwise, better thing is to give voriconazole, or if not possible, then give amphotericin. And least drug of choice is the caspofungin, or you can use it in combination but not as monotherapy. And coming to amphotericin B for aspergillosis, for invasive aspergillosis, ampho is not the drug of choice. Voriconazole is the drug of choice. But if you are not able to give voriconazole, you have to remember that amphotericin B does not cover all species of aspergillosis. Sometimes some species of aspergillosis, like Aspergillus flavus, it has a lot of resistance to amphotericin. So if you are giving a patient amphotericin, you can't think that it will cover each and every fungus. It has its own limitations. So coming to source control. Source control is important for any infection like bacterial infection, fungal infection. You are having lots and lots of pus in your body, abscess everywhere, and you are just giving antifungal or antibiotic. It is going to develop resistance, but the patient is not going to clinically improve, or they'll relapse. So source control is extremely important in uh, infectious diseases. Uh, for mucormycosis specifically, extensive debridement, maybe repeated debridements are also needed for the clinical improvement and to decrease the mortality. And coming to Candida, if there is Candida bloodstream infection, the duration of treatment for Candida bloodstream infection is 2 weeks after the first negative blood culture. It is not like if you are starting echinocandin today, you have to just give 2 weeks and then stop the treatment. You have to send blood cultures ideally every day, or at least alternate day, and then see the first day of negative blood culture, and then from that day you have to count 2 weeks. That is a bloodstream infection. And if the patient of candidemia is having blurring of vision, you have to do fungal fundus examination and see whether there are any infiltrates in the fundus. And if there are any infiltrates, you have to increase the duration of treatment to 4 to 6 weeks sometimes. And you have to have it check 2D echo to see whether there is any endocarditis. Or for Staph aureus and Candida, both if they are growing in blood culture, you have to have a check 2D echo and examine the patient's palms and soles and pulses to rule out any embolic manifestations of infective endocarditis. So sometimes we see hepatosplenic candidiasis with candidemia. It is usually seen in hematopoietic stem cell transplant patients during engraftment, when the neutrophils are coming up during engraftment. So it will cause tender hepatomegaly and fever and pain, all these symptoms. So you have to have the background of hepatosplenic candidiasis is also on in neutropenic patients. So duration of treatment is prolonged for hepatosplenic candidiasis, and you have to decide depending on the imaging also. Sometimes 2 to 3 months may be needed. And coming to line, so it will also come under source control only. If any virulent organism is growing from the center line and the patient is hemodynamically unstable, then you can't just not remove the line. You have to immediately try to take out the line and put in a new line. And duration we have discussed. I would like to take this opportunity to discuss a little bit about TB and ATT-ART. So any patient, if you are sending suspecting TB and you are sending investigations, always try to send not only AFB stain and culture, but also GeneXpert Ultra, because in India, there is a lot of drug-resistant tuberculosis, pre-XDR, MDR, XDR, TB, TDR also, sometimes totally drug resistance also. So once you lose that opportunity initially, the patient will be just roaming around for 3 to 4 years without a proper diagnosis, just taking first line TB and just worsening. So we have seen so many patients with drug-resistant tuberculosis taking first-line treatment without having any background resistance testing, because the physicians are starting only TB treatment depending upon the AFB stain only. If AFB is positive, then you just start AKT. It's not like that. You have to send gene expert ultra and also TB culture so that you can confirm whether there is drug resistant TB, there is isoniazid monoresistance also. Because gene expert ultra will not give INH resistance, it will only give rifampicin resistance. So if a patient is having INH monoresistance also and you are giving first line AKT, the patient will not improve. So you have to confirm with the TB culture ultimately. So this I wanted to tell you. And steroids in TBM. In TB meningitis patients, we prescribe dexamethasone. So the tapering of steroids needs to be very slow. Otherwise, the patient will have paradoxical reaction with increase in the meningeal reaction, and the patient will end up in neck pain, seizures, again altered sensorium after initial improvement. So the tapering of steroids should depend on patient to patient. You have to clinically monitor the patient at every visit and maybe try to go back to the previous dose of steroid if the patient is worsening clinically. And IRIS and ART and AKT. So IRIS is immune reconstitution inflammatory syndrome that we come across in HIV patients usually. So in IRIS, basically what happens is initially the patient with HIV comes to you with a very low CD4 count, and the patient doesn't have any immunity to fight against any infection. So when you are giving the HART or highly active antiretroviral therapy, the patient is suddenly having increased CD4 count and he is ready to fight with any infection right now. So when there is a fight with the infection happening, so there will be response, inflammatory response like fever, increase in the size of lymph nodes, worsening sensorium, worsening breathlessness, and all these symptoms. So whenever you come across it, newly diagnosed HIV patient, don't just jump in and start ART. You have to rule out all the opportunistic infections like tuberculosis, cryptococcus, even syphilis. Try to rule out all these infections. If you have diagnosed any infection like TB or cryptococcus, you have to treat for 2 to 4 weeks depending upon patient to patient, and then after you get the relief of symptoms to the primary disease, then you go and start ART and monitor the response. So after starting ART, if you get the paradoxical response, it is not an indication to start ART, but you have to just give steroids and then continue the HIV treatment. So when a HIV patient is having TB as well, so the first drug you need to start is ATT, and after 3 to 4 weeks, depending upon the response, you will start ART. So thank you. I hope you have enjoyed the lecture. So my next lecture will be on interesting cases in infectious diseases which I have come across. So thank you.